Um, Thank you very much for inviting me again. I think I've made it to pretty much every KCNQ2 summit since the first one in Denver, and I really appreciate being part of this. Some of you who've been to the previous summits will recognize some of the slides and message here, but I think it's important information to be reminded of, and also uh, for new parents to be aware of, as far as the different types of presentations and how the children might change over the subsequent years since the initial presentation. My talk, I'm going to focus on the loss of function variants primarily. I'll talk about how to diagnose epilepsy in general, and then focus in on KCNQ2, and talk about the seizure presentation and the EEG patterns. And then I'm going to talk a little bit about some of the later seizure types that I've seen in older kids with KCNQ2 loss of function, and then some cases of dystonia and something called myokymia, which I'll describe. And then at the end, I'll just touch very briefly on some rare gain of function variants that have been described in the literature. I think that's a question that comes up often. How do I tell the difference, or how do I know whether my child has loss or gain of function variants? And I think in my mind, it's fairly clear. So just very basic, when you go to see your doctor with spells, or there's a baby in the newborn nursery with some spells that are concerning, the first thing that we think is, are they seizures at all? And if they are seizures, what type of seizure? And then finally, what is the cause of these seizures? And do they fit into what's called an epilepsy syndrome, which I'll describe in the subsequent slides. So the epilepsy syndromes are made up of several criteria. We look at the age of onset of the patient. When do they start having seizures? If they're a bit older, what has their development been like up to that point? What types of seizures are they having? What does their EEG look like in between and during the seizures? And that helps us have some information about the possible epilepsy syndrome, if they fit into one, and then can give parents a prognosis, what to expect in the future, and maybe tell us what type of medications to use. And when a child is having seizures, as I mentioned, we want to figure out why. And some of the things that your doctor might do is order an EEG, which we'll talk mostly about today, MRI, which is usually fairly normal in kids with KCNQ2. And then I don't need to go into genetic testing because Dee did such a great job covering all of that already. So how can an EEG be helpful for a patient with KCNQ2? So it can support the diagnosis. There's some patterns that we see with KCNQ2 and some that we don't, or it can help us differentiate the different types of KCNQ2. We know the child had seizures as a baby, but then they're 6 months old and they're doing something else. Are those seizures? We can figure that out using an EEG. Are they having new seizures? We definitely know they're seizures. What type of seizures are they? Has there been some change in the child's condition? Have they been more sleepy, or are they having a regression in development? The EEG can also be helpful for that. We can differentiate, the child's on 4 different seizure medications to control the seizures and is very sleepy. Is it because the condition is getting worse, or is it because they're on too many medications at too high of doses? The EEG can probably help figure that out as well. And then maybe something that's not done as much, we want to confirm that the child's actually doing as well as we think. So hopefully parents sleep at night and are not watching their child every minute of the day. And there might be seizures that they're unaware of overnight, for example, and a prolonged EEG can be helpful sometimes to reassure both parents and the physician that the child is fully controlled on the current treatment regimen. So, Scotty told me not to get into the weeds too much with how to read an EEG, but I think it's helpful. I've heard from some parents who've heard these lectures to know some of the terminology, because you guys get all your medical records now, and you can see the reports, and you may not know what all the terms mean. So when we say the EEG background, we're talking about what does the EEG look like during wake, during sleep, in between the seizures typically. And that can either be normal, and the caveat there is normal for age, because the EEG is a moving target. The normal will look very different for a newborn than it will for a 2-year-old or a 12-year-old or an 80-year-old. And some of the things we might mention on the report as far as the background is slowing. So the waves, the brain waves are slow. So the speed of them are slower, and either in one area of the brain or all over the brain at once. So the terms we might use is focal, and then diffuse and generalized are used fairly interchangeably. And then what do the spikes look like? You might also see the term epileptiform discharges. Those are what show excitability in the brain and a predisposition to seizures. So there might be no seizure or no spikes, even though your child has seizures. They might all look alike or be called stereotyped in the report, or they might look different from each other and be called pleomorphic in the chart. And where are these spikes located? Are they in one place, similar to the slowing, focal? Multifocal, you might see in a child's report with KCNQ2, many places in the brain, technically on both sides of the brain, and a minimum of 3 spots. And then generalized or diffuse might be used interchangeably. Sort of the spike goes through all of the areas of the brain at once. And you can take these different terms that I've just described and put them together in different combinations, either no spikes, normal background, spikes that look alike and are generalized with a normal background, etc., and make up classifications or categorizations of EEGs. And this is a system that was developed by Doug Nordley. And we're going to talk mostly about group 4, and put on a different backdrop here is group 4 again, but also looking at the epilepsy syndromes that are described by our International League Against Epilepsy, and the age of onset, neonatal, infant, child, adolescence, and variable. So I don't want you to read all of the text on this slide, but just know that if your neurologist identifies your baby's EEG as being having multifocal spikes and background slowing, and you know that the seizure started in the neonatal period, there are not that many epilepsy syndromes that could be diagnosed. There may be no epilepsy syndrome because they don't quite check all the boxes for that specific epilepsy syndrome, but the number of potential epilepsy syndrome diagnoses are very small. So they're not, this type of framework should help them zero in on what's going on with your child. So I'll just give a tip of the hat to Dr. Odahara from Japan, who studied EEG and epilepsy in the 70s and first described burst suppression and Odahara syndrome, the type of seizures, which many of the children with KCNQ2 have been associated with. And this is one of the figures from his 1976 paper. So this was not recorded with a computer EEG, but rather a pen and paper EEG. And so it looks a little bit different from our EEGs today. But you can see the burst here. It's quite simple visually to see the burst, and then the area in between is suppression. So applying KCNQ2 to this framework that I've described, you can see that there's 2 main types of KCNQ2 loss of function phenotypes. The word phenotype means clinical presentation. And I'm going to talk first about something called benign familial neonatal epilepsy. So just very simply, they should have a normal EEG in between the seizures and have seizures that begin in the neonatal period. And we know from work done by my neonatal neurology colleagues that KCNQ2 is the most common cause of neonatal onset epilepsy, at least in this cohort that was tested with SCN2A as a close follower. So benign familial neonatal epilepsy, they'll have similar seizures to the more severe end of the spectrum with brief seizures, tonic seizures, clonic seizures, and this apnea and often a scream during the seizure. And they will be treated with phenobarbital, probably. It's the most common treatment for babies since the 70s or before. And will probably self-resolve with that medication or resolve with that medication. They will have a normal exam, they will have a normal EEG, and they'll have an evaluation probably looking with MRI, looking for infection, looking for other causes of seizures in a newborn. I don't think a neonatologist wants to miss anything. The prognosis is good. Most kids will grow out of this seizures, but some percentage will have seizures later in life and will usually have normal development. But as we've learned more, there is a spectrum. So it's not quite as cut and dry that kids will have the benign familial neonatal epilepsy or the more severe KCNQ2 DEE that I'll talk about next. But some kids are kind of in between as far as seizure frequency, severity, and developmental severity. I get asked a lot by different types of people, how can you tell if a kid has benign familial neonatal epilepsy? Well, you can do the genetic testing, and that will be one piece of the puzzle, because there's certain variants that are associated with a more benign or self-limited presentation. But I think one thing for me clinically and with my use of EEG, I think that the EEG in between the seizures should be normal or nearly normal. You might need to get some expert opinions about this, because sometimes the phenobarbital can affect the EEG a little bit. Frankly, reading neonatal EEGs is tough. And you might line up 10 epileptologists and get a couple of different answers if they're all looking at the same EEG. So next, we're going to talk about neonatal onset with this type 4, which you all know means multifocal spikes and an abnormal background. So you'll see there it can either be associated with something called early myoclonic epilepsy or early infantile epileptic encephalopathy, so named after Dr. Akardi or Dr. Odahara. So the KCNQ2 DE, they will present usually with the tonic seizures in the first week of life. They can be a little bit later, or they can have some slight variation to their seizure type. And generally, the seizures will be very frequent in the very beginning. As they get older, they will diminish, may not stop, but will definitely slow down as they get older, a couple years old. The infantile spasms may develop in the sort of 3 to 9 month or 3 to 7 month range after the other seizures have ceased. The EEG is discontinuous. It has this burst suppression pattern like we learned from Dr. Hodder-Hara's slide, and will get generally more continuous. And I have a slide to show you what that means. But we'll have multifocal epileptiform discharges. And then the intellectual disability and behavioral issues are often associated with KCNQ2. But as I said, there's a spectrum, and not every child is the same, even with the same variant. So here's an example in comparison to Dr. Odahara's burst suppression of a neonatal EEG in a child with KCNQ2. So we might use the terminology excessive discontinuity for age, so it's not quite burst suppression, and multifocal epileptiform discharges. So here's the discontinuity or the suppression, but you can see that there's brain activity in much of this page of EEG. And then I put little circles around some of the spikes. They're really all over the place, but just to show you the 3 different areas on 2 sides of the brain. So I've got several cases to illustrate the different types of clinical presentation that I wanted to cover today. So here is a neonatal onset encephalopathy or loss of function KCNQ2 DEE. So after birth, this child had no initial concerns. And then on the second day of life, there was some issues associated with feeding, whole body stiffening, head deviation, crying, heavy breathing, and turning blue around the lips, also called perioral cyanosis. Very brief and occurred a few times per day. I think it was brought to the attention of a nursery nurse, but it wasn't witnessed, and they thought maybe it had something to do with feeding. They went home, and then the pediatrician heard about this, saw one, and ordered an EEG, which is shown here on the right. And now all of you can look at this EEG page, and you can tell me what it shows. Because of the little primer we just had. You can see the bursts alternating with the periods of suppression. You can see that all the examples I've shown don't all look exactly the same. There's going to be some variation child to child, day to day, minute to minute. And here's a video. Hope you can see that. The child was admitted to the hospital several months later, received, after continuing to have multiple seizures at a local hospital, came to a epilepsy center, was admitted, had IV phosphonatoin, which immediately stopped the seizures that this child was having, despite 3 other seizure medications. On the video, you can see the baby having a eye deviation, stiffening, moving the arms, turning sort of blue in the face, and letting out this cry. I hope you could hear. After starting carbamazepine medication, a sodium channel blocker, there were no further seizures after that. And genetic testing later showed KCNQ2 variant. The EEG, there's sequential panels here of time. So as the EEG started, it kind of went flat. This black stuff here is muscle artifact from the baby tensing the muscles, and it's fairly flat. And if you could look at it more blown up, you could see that there was some very fast activity that built up and got slower and higher in voltage, the pattern that we see with tonic seizures. And then at the end, it starts to go back to normal as the baby relaxed. So just a timeline for this baby's diagnosis. So 2 days of life, started having these typical seizures, tonic seizures. They knew they were seizures within the first week. Everything else was negative. As they were waiting for second opinions and in a time when there was a need for insurance pre-approval for genetic testing, the child was having 25 seizures a day and on multiple seizure medications. They referred to an epilepsy center. It's not a bad idea to see an expert at an epilepsy center where this genetic syndrome is studied and it was recognized. And even before receiving the genetic testing result, the treatment was changed to something that would be more effective for KCNQ2. The seizures ceased. And I like to call it precision therapy because the genetic testing and the recognition of the syndrome allowed for change of treatment and for controlling the child's seizures. As the child's gotten older, despite controlling all the seizures, the child's development has been impaired, and the two don't always go together. So I just make a point here that really could have made this diagnosis or had a suspicion of the diagnosis as soon as they presented. As soon as we saw that EEG and all the other tests didn't show something else, infection or stroke, we could have guessed it was possibly KCNQ2, as I showed you, the most common cause of neonatal onset seizures. So next, another child who presented very similarly, but later developed other seizure types and dystonia. So you can see this pattern. See, it looks a little bit different. The first page here. Burst suppression looks a little bit different in this child than it did in the first child. But seizure onset, first day of life with focal tonic seizures. You can recognize that pattern too of the focal tonic seizures. You can see that it's kind of flat, and you can see this fast activity. When people say, is it hard to recognize these patients? Sometimes I say no, it's not that hard once you've seen several of them. The seizures initially responded to phenobarbital, which lots of seizures do, but they continued, and the child had an extensive evaluation. This child was born many years earlier than the first child described, so we didn't have a good understanding of KCNQ2 and what treatments might be helpful. They evolved to infantile spasms and hypsarrhythmia by 2 months old. The epileptic spasms and brief tonic seizures remained refractory to multiple treatment trials, and the developmental outcome was with intellectual disability, difficult walking, and unable to talk or walk. The KCNQ2 variant was finally discovered at a couple years of age rather than a couple of months. So here's a slide just showing this child's evolution of EEG, which I think is important for parents to understand. You have this sort of burst suppression pattern at birth, which then at a couple months of age, you can see it's getting more continuous. So when your doctor says it's getting more continuous, you can see the difference between the bursts and the suppression. And now there's some bursts and some hint of suppression there. And then in the four-month-old EEG, you can see that it's more or less continuous, and the spikes are starting to decrease. Now this child, this pattern in sleep at 2 years old, and having tonic seizures. I put some arrows here so you can see where the tonic seizure starts. This blue thing at the bottom here is what's called an EMG. We will put these on the shoulder of the patient to try and see when the muscles stiffen. Not every hospital will do that, but it can be very useful, especially when the seizures are subtle. And the change in the EEG is fairly subtle. I put this EEG background in between seizures so you can see a little bit better how it changes. So at the time that there's a clinical change in the child, you can see that there's a change in the EEG, which is fairly subtle, but you can see that it gets relatively flat. And there's some faster frequencies as well. And then another seizure type, which I think is often missed, and honestly was missed in this patient because they were having very brief seizures or brief EEGs, these routine EEGs without video. These type of EEGs may not be able to pick up things that are so subtle like this, and especially without, again, this one, in this case, green EMG down here, alerting the reader that there's some subtle stiffening of the patient. So again, these are the spasms occurring in clusters as the child is falling asleep. So here's one of these brief tonic seizures. The extension of the arms there, which correlates with the arrow, the stiffening of the EMG, and the flattening of the EEG. All this black stuff here is just muscle artifact and not something that is coming from the brain. And then a little bit later in life, this child developed dystonia, and I hope you can see the video playing now of the child moving the arms, writhing, gaze deviation, opening and closing the mouth, quite distressing. And a definition of a movement disorder is involuntary muscle contraction causing repetitive movements and twisted postures. You know, with a video of this or a doctor witnessing this can help make a diagnosis of dystonia. And many times patients will be referred for EEG because there's concern that these might be seizures. And we will see EMG or the muscle activity on the EEG, but we won't see changes in the EEG that would make it consistent with a seizure. Now, the treatments, which were partially effective for this patient, medication called ezogabine, which isn't available currently, carbamazepine, and diazepam, which made the child sleepy, ineffective. Acetazolamide caused some ear discomfort possibly, and another medicine called gabapentin. In general, dystonia treatment is individualized based on the side effect profile and cause or etiology. So that's the same thing with anti-seizure medications. The anti-seizure medications that are often used are carbamazepine, acetazolamide, and diazepam. And other medicines your doctor might recommend if your child's having dystonia, something called L-Dopa that you might know from Parkinson's disease. A mouthful here, trihexyphenidyl, or something called baclofen, and there's others. So don't be surprised if some other medications are recommended, which they explain are not used to treat seizures. Consulting with a movement disorder specialist might be helpful to confirm the diagnosis and to get a treatment plan. And in my experience, the movement disorder doctors will often say, well, is it distressful to the patient rather, not just the parents? And that will help them to decide whether they recommend treatment or not. So the last case of loss of function is a myokymia case. So this is a sort of funny Greek word. It means muscle writhing or muscle movement. This child had onset of seizures at 2 days old. We've heard this before. The video EEG showed multiple focal seizures from either hemisphere. There was multifocal epileptiform discharges and a discontinuous background. That seems consistent, right, with KCNQ2 encephalopathy. The family history of mom and sibling with neonatal onset epilepsy is something we always ask about. And in this case, it was positive. Mom was treated with phenobarbital. She was off medications for her adolescent teenage years. But she had seizures when she was later pregnant. So she must have had some continued risk for seizures. There's also an older brother who had a seizure at 3 months and had a little bit of a developmental delay, and a sister who never had seizures at all. The birth history was normal. MRI and other tests looking for other causes of seizures were negative. So this child ended up having a variant, a very specific variant, inherited from mom. Child had some mild speech delay. The phenobarbital controlled the seizures initially, and eventually topiramate was added for breakthrough seizures, and topiramate continued after that. At 5 years old, the caregiver called the neurologist and reported worms in the thighs, which was what her words and her description of it. Now, this kind of subtle. I hope you can see in the video that the child assented to having this video done in the clinic of her leg muscles kind of having a worm-like movement. So there's muscle twitches in the thighs that occur several times every minute. Didn't bother the child at all and just kind of happened all the time. So if your doctor gets this variant, the 619T to C, and goes to the Ricky website that Dr. Cooper is going to speak about, I believe, you can learn all about how this child has a very specific presentation that can result in myokymia, which is this muscle movement. It's also noted here from other cases that have been described in the literature that the seizure severity and degree of intellectual disability is is highly variable. So I mentioned the other family members, the mother, the brother who also had seizures, and the sister who didn't have seizures at all. So there's a great variation in how this can present in each patient, even in the same family. So finally, I'm going to talk about the rare gain of function variants, just because I get this question a lot. How do I know that my child has loss of function or gain of function variants? And I think we're learning more all the time about the different presentations, but I think this is something that's fairly well established as far as the main classifications of gain of function and loss of function variants. So first, I'm going to talk about onset of West syndrome or infantile spasms without without neonatal seizures. So in this paper, myself and colleagues across the world talked about 4 infants who presented with infantile spasms, so at about 4 to 6 months old, who didn't have neonatal seizures. These were fairly typical infantile spasms in clusters, and the EEG background showed hypsarrhythmia, which is a typical pattern on the EEG in between these types of seizures. And they all had this certain variant, the R198Q, which was shown to be gain of function in the lab tests. All these patients, up to the time that they were studied, were eventually seizure-free, but continued to have moderate to severe developmental delays. So I don't think we would confuse this group of patients with patients who have a loss of function variant, as I described in the first 3 cases. And then the last rare gain of function variant I'll talk about today presents in the neonatal period. So doesn't really fit into the EME or the EIE, the Aicardi-Ohtahara syndrome, but is in this, this age group. So these patients have, was described by my other colleagues from the KCNQ2 research community, had myoclonus without EEG correlate from birth. So I think it can be difficult to differentiate when a baby is jerking, it will move the EEG or move the patient, and that can cause some artifact on the EEG. So it might be difficult for certain EEGers to differentiate whether there's an actual change in the EEG or it's just muscle jerks. But in this case, the experts conferred and reviewed the EEGs and decided there was no change on the EEG. It was just muscle movement, which is an important point. They had trouble breathing. They had respiratory failure or had slow or low breathing. And they all had this R201 variant, which was shown to be gain of function. All these children had profound developmental delays. So again, you can see how this, even though it's in the same age of onset, I wouldn't see the focal tonic seizures that I showed you examples of, and I would be able to have a good idea that the child didn't have this gain of function variant. So in summary, I have some take-home points. Did something change with your child? Is there a new spell that you're concerned about? I recommend asking your doctor about getting an EEG. It can be very helpful for differentiating these things, whether they're seizures or hopefully not seizures. And I think it's important for us and now you as an informed and empowered parent to educate your neurologists and geneticists and neonatologists about KCNQ2, recognizing this onset in the neonatal period and selecting the right type of seizure medication from the get-go is very important for controlling seizures. And these important questions about loss of function and gain of function can be answered pretty simply in most cases by understanding the different presentations that I've discussed today. And not all paroxysmal events, that's the fancy way of saying spells, are seizures in KCNQ2. You can have dystonia or myokymia, and the dystonia is distressing to the child and may need treatment and a change in treatment from what you're currently receiving. And could dystonia be another outcome for clinical trials along with developmental concerns? These are important questions and things that need to be recognized and further described in order to understand them better. So with that, I'll take questions.
Thank you, John.
We got us a little bit back on schedule.
We appreciate that, and thanks for being such a long-term supporter of our community and participating in all of our summit meetings over the years, and hope to get back to seeing you in person again.
Yes.
Some of the things you mentioned about the EEGs, we have several questions on the chat. Try to roll some of these together, but oftentimes parents see a normal EEG and yet the child still has significant developmental issues. And so to what extent can the EEG be used to determine anything about development? Is there anything that you can look at in the EEG that will give you any kind of information on anything other than seizures, how the development might be going? Is it predictive and that sort of thing?
Right. So I wish the EEG was that powerful that it made the crystal ball and prediction very, very clear. I think there's certain situations where I give the EEG more weight than other situations. When the baby is first born, as I mentioned, if the EEG is completely normal in between the seizures, then I would lean more towards the chances, not a guarantee, but chances of a more a better developmental outcome and something closer on the spectrum to the so-called benign familial neonatal epilepsy. As children are older, I have seen this, that the EEG essentially normalizes by 2 or 3 years of age, and the child continues to have developmental concerns. And I think it just illustrates that the EEG is sensitive for picking up developmental issues, but is not super specific. So I think there can be situations where the EEG is very abnormal, but in the background and the child's doing very well, and the vice versa. But the caveat to that is each patient's an individual, and I'm a very big proponent of serial EEGs, with the disclaimer that I make a living reading EEGs, but I think that they're very useful to see the changes in that individual. And if the child's EEG was normal and then they had a clinical change and I did an EEG and the EEG is abnormal, that might give me a clue that it has something to do with the seizure medications, as I proposed before, or some slip into hypsarrhythmia, or some slip into encephalopathy, or having lots of seizures that the people weren't aware of. So I think it's important to use that individual patient as its own control or as its own comparison.
Okay. And then how much, and you touched on this, how much is the development impact related to seizures versus the specific variant that an individual might have?
So I think this is a very important question, and I think we have a lot of lectures about this today and yesterday, and I don't know that we can be super precise about predicting exactly how the child's going to be, but we have a fairly good idea, especially as we get more numbers of patients with the same variant. We can predict that there'll be some range of development in EEG or development in seizures with that specific variant. But myself, with patients with KCNQ2 and also with other genetic causes of epilepsy, ion channel causes of epilepsy, that the same patient or patients with the same variant can have different presentations. And I think that's related to things that Dee probably talked about, the other 19,999 genes that we have and making that child an individual, and also the environmental and what exposures they had. So to answer your question, I don't know exactly, but I think it's another piece to the puzzle, which can help us predict as best as possible.
And then a couple questions from the chat about infantile spasms. Did we understand you to say that they're specifically related to gain of function variants in West syndrome, or could they be loss of function as well?
Good question. So they can be seen in both. And that's an important question. So I've seen many children with the loss of function. So they have neonatal onset seizures, the tonic seizures, and then they evolve or change into infantile spasms when they're 4 to 6 months of age. I hope I didn't cause confusion. The gain of function, the rare gain of function cases that I described at the end there, they didn't have neonatal seizures, but developed infantile spasms as their first seizure type at 4 to 6 months of age. So yes, either loss of function or gain of function can have infantile spasms, but the difference is, did they have neonatal seizures or not?
And related to the infantile spasms as well, there was a question whether you would consider CBD an important treatment option for those.
Myself, I use in patients with KCNQ2 and really any cause of epilepsy, I use the FDA-approved treatments for infantile spasms because I believe them to be the most effective. This is ACTH and vigabatrin. So I have not personally tried using CBD alone for infantile spasms.
Okay, and then just in that vein of treatments, what we see across the patient community is a large range of different treatments that are evaluated. And do you have something, a go-to that you think is the optimal approach for first-line treatment for children presenting with KCNQ2 DEE?
Yes, the children with the loss of function variants who are having these frequent tonic seizures respond best to a sodium channel blocker, and usually the thing that's tolerated best is either carbamazepine or oxcarbazepine or some other variant of a sodium channel blocker.
Great. And then one final question is, especially as we look at more targeted therapies coming towards the market, how do you approach determining whether a particular variant is a gain or loss of function? You talked a little bit about this, and some of the other presentations over the last day have raised the question that there's some nuance in determining that. So we're interested, as that seems to be becoming more important with new precision treatments, how you go about determining which category a variant falls in, particularly if there's not any seizure activity.
If the child's not having seizures at all?
If the child isn't having, the question from the chat was if there's no active seizure activity, whether that becomes more confounding.
Well, I think there's going to be, new, as more and more cases are discovered and described, there's going to be, new, the rare gain of function variants that I described, those were just, literally a handful of cases. And so there's going to be a handful of cases of different variants with different presentations that are going to continue to come out as we learn more. But I think that the classic presentation of the neonatal onset focal tonic seizures with the discontinuous EEG and multifocal spikes would lead me to consider that patient a loss of function versus a gain of function.